what is the back's capacity for recovery?
I'm trying to think if I should answer that generically first. Can I go back just a little bit and ask a very simple question? What is an injury? Some people will say, I have an injury because I have pain. Or another person will go and have a scan, and the radiology report will report a feature, and they'll say, that's an injury. Or they might come to me, and in our assessment, we will see, and if I can just show this, Youssef, so there obviously is the pelvis and three sample vertebra. Now, I will bet with you, when you had a disc bulge, it's like letting a little air out of your car tire. The car tire bulges a bit, but it loses its turgor, its stiffness. And remember, stiffness controls movement. So now the car is a bit sloppy driving down the road. So watch. Here's the disc that has been damaged. You can't see it, but trust me, it's been damaged because one of the definitions of damage is a loss of stiffness. So if we did a stress strain load on that tissue, just like a torn ligament or a strained ligament, it would have a broader neutral zone. It's been stressed and strained. But now I'm going to watch, I'm going to load this spine in twist. Do you see that the normal joint moves a tiny bit? This normal joint down here moves a little bit, but focus your eye now to 4L5. Do you see the massive amount of shear motion occurring at the damaged joint? Posteriorly, we see much more load into the facets. So that's why facet pain is usually secondary to disc damage as the joint gets flattened. More load is on the facets, more motion now is being seen by the facets, and they start to wind up. So what started out as a flexion experience now becomes flexion and extension. In other words, they're motion intolerance. Anyway, getting back to this notion, how do you see that? We'll do a prone flexion instability test and probe and find out where the person's pain is. We might do a fluoroscope when I'm testifying, for example, in cases of whiplash. The patient will be told by the traditional medical system, you've had an MR, there's no visible damage on your neck, you're a pain catastrophizer. That should have healed within 12 weeks. And I say, wait a second, show me your pain, and the person will go through a range of motion, and then they get a movement catch in the mid-range. I know what I'm dealing with because I've seen it many times. Let's take a fluoroscope if the court needs proof, and then you will see as the spine flexes at the joint that has lost its stiffness, it suddenly clunks. Ooh, there's my pain, perfectly correlated. We know precisely that it is that loss of stiffness, not detectable in any other way, that is causing their pain. So do you think stretching your neck is going to help that particular person? No, we might start off with a pattern. Push your tongue hard to the roof of the mouth. Touch the teeth lightly together. Grimace down with the corners of your face. Create that, the flexor response. Now, under that pattern, put your fist underneath. Now apply 1 kilo of upward force, no more, and hold it for 5 seconds, just 1 kilo. Start to set the pattern now that now you're putting muscle memory into your brain. And for the first time, push the tongue to the roof of the mouth. Now, let's go through the offense. In disbelief, they didn't get the clunk, and the pain was arrested immediately. So there might be an example of, we're talking about a defining injury and pain. Do you see how we have to go through these various layers? So when someone says to me, there's no pain mechanism detected on an MRI, and I think you're a junior diagnostician. You haven't done your job. If you can't find the pain, sir or madam, you better go back, get your skills up, and go and find the pain in that particular person. So there's an intro to this idea on the question, which I think was about the capacity for recovery. So I don't know if you want to comment on that, and then
Yeah,
I'll address the question that you gave me. But do you see where my brain went?
yeah, absolutely. So what you said there is obviously clinical assessment is key, and often people will prematurely do an MRI before they've done a complete clinical assessment, and then you haven't really got much to correlate it against because you're looking at something which may not be related or may even be a red herring for what's happening clinically. And the second thing you mentioned is the second order effects. So when someone looks at whiplash or a disc injury and says, there must be one piece of anatomy involved in this, and that's not damaged, or that is damaged, and therefore that's the cause of the pain. Whereas you've said here that this is about the second order effects sometimes, where it's not so much the disc in itself or the disc that could be seen from an MRI, but it's the way that it behaves under load or under movement. And then looking at the patient and saying, okay, what are they specifically deficient in? Stiffness or flexibility, for example, and how do we calibrate that to for that specific patient? So some really interesting stuff in there.
Yeah, precisely. With me, I broke C4 when I was in my early 20s. It's got a good chunk out of the front. When I was a younger man, I needed neck stability to subdue that mechanism, and I was able to manage it very well. Now I'm in my mid 60s. I don't need stability. Nature has gristled it all up. I need mobility. So now, when I was a younger, stronger man, I would tune my self interventions, probably with a bias towards strength and stiffness and that kind of thing. But now, as an old guy, I need mobility. Now, isn't that interesting? Just the life cycle of did that tissue heal? Because we're talking about the capacity for recovery. Isn't it interesting how that story now opens up to one of adaptation that goes on for years? And talk about an MRI, it shows the full history of that person's life. It shows all of the old scars. So you'll see the scar of a broken C4 with me. But now, what is a fresh wound? What's causing the pain? I can deal with that with mobility when that was poison to me a few years ago. So the capacity, you've read Gift of Injury,
Yeah.
and that shows, again, if I go back to establish a scientific concept before we get into that one, in many respects, the language of cells to deal with injury is force. Mechanostimulation, you can think of any system in the body, whether it's hormonal, musculoskeletal, everything depends on that signaling of force. Now think of even psychology, where you get a textbook on clinical psychology and you go to the chapter on clinical depression. What are the postures that clinical psychologists are taught to interpret as depression? Knees together as they sit, sitting with their hands crossed in front of them. There is a classic indicator, pattern recognition for clinical depression 101. Get the person, sniff a little air, get some fight or flight going, get under some load, feel what it feels like just to put 50 pounds on your back. Take command. You know what I mean? And so now that person says, I own the world. I own my pain. I command the load around me. So you've just saw a personality change in me. For that beaten down person, I'm quiet and sympathetic. But then I'm going to build a warrior, someone who commands all that out of their body, and they own the world. What a psychological shift. So what's the capacity for recovery? You saw it with Brian Carroll anyway, in terms of mechanostimulation. The man had set a world record in squatting. It was just over 1,000 pounds. He had split his sacrum with a fracture. He'd really heavily damaged L5 and the disc above and below. If you look at the MRs, no one's going to argue it. That was a very damaged spine. He did mechanostimulation, bone callousing, which was just an experiment because I didn't know what else to do. So it was an experiment in progress. And I said, here's what I do know about it, and we'll run it as a year trial. Anyway, long story short, that was 2013. 1 month ago, he set the all-time all-weight record, squat record. He squatted 1,306 pounds, and he's
What a
never had
story.
back. He's never had back pain since. But the nice thing was, look at the MR today. He has been able to remodel his spine remarkably. All of the vertebra and discs above the damaged L5, they look fabulous. It's incredible that someone can do that and still look normal in their spine. But he has remodeled, but he was very scientific about it. And I'm not promising that with everybody. And the other thing is tincture of time. as time will just bristle and stiffen. And if it's a motion-based pain trigger, that will slowly go away. But the key for the person is to how to learn to manage it in the meantime. Anyway, I see your face and I'm talking too much. I apologize.
No, this is going to be really encouraging for people listening that it is possible with the correct management to remodel the spine into something because I think for some reason the back is always seen as a much more permanent injury than any other joint, and it seems to have this special status that back injury is like a death sentence. And to see the cycle of Brian's progress having from a tissue level much worse injuries than many people will have faced, and yet has gone on to outperform his previous personal bests is massive.